Hello and welcome to today's webinar, Administrative Concerns in Street Medicine, Assuring Quality Without Sacrificing Mission. I'm Michael Durham and I will be your moderator for the webinar, which is presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last portion reserved for Q&A. Please use the chat box below the presentation slides to get help with technical issues or to ask the presenters a question. If you are experiencing technical issues, you may instead call the Council's office at 615-226-2292 and ask for Caroline. This webinar is being recorded and will be archived with the presentation materials at nhchc.org within 3 business days. Our presenters today are Laura Lacroix, the Clinical Coordinator at the Street Medicine Program of Lehigh Valley Health Network in Allentown, Pennsylvania, and Brett Feldman, who is the former Director of the Lehigh Valley Street Medicine Program and the new Director of Street Medicine at the USC Keck School of Medicine in Los Angeles. So before we get started, we are going to do a poll of the audience to see what kind of people you are. So we're going to go ahead and pull that up on the screen. Please take a moment to tell us what best describes you, and we'll close it in just a second. A good mix of folks, 0 government officials so far, maybe that's a good thing. Mostly people from health centers, so, and a good group of others. So next we're going to ask you to tell us where you are at in your street medicine programming, whether you're in the research stage, whether you're making progress but not yet fully operational, whether you have outreach but not with clinicians present, or whether you have an operational street medicine program currently working. Please take a moment to address that. All right, looks like a good majority of folks have an operational street medicine program, so that's good to see. All right, thank you. We at the National Healthcare for the Homeless Council have observed an increased interest in street medicine recently, which may be related to the rise of encampments and really homelessness in general across the country. So we're very excited to hear from such experienced professionals in this clinical specialty. So with that, Brett, please take it away.
All right, thank you. So as Michael said, my name is Brett Feldman. I'm the Director of Street Medicine for USC at Keck School of Medicine and also the Vice Chair for the Street Medicine Institute. Part of the necessity of doing this webinar is because in the past few years, street medicine has really been undergoing a transformation from being a grassroots movement to a legitimate healthcare delivery system while being able to maintain its mission. With the goal to deliver the same high quality of care that you would expect in a traditional setting delivered on the street. And having a good quality assurance and risk strategy is key to making sure that the care you're delivering is quality and also not putting yourself or your organization at risk. So one of the questions is, how can somebody who's delivering care like this have the same quality as in a traditional clinic? So this is me. I know you can't see me, but I'm crawling in a tent outside. You can see the blood pressure cuff on the side and my backpack where I have the medications outside of the tent. But what you don't see is that at the time of this visit, this patient had a consent to treat form, a HIPAA release, their payer information was updated in the EMR, their vital signs were taken. Yes, this visit was done in a tent, but at the time that this visit took place, the patient had their hypertension controlled, their A1C went from 13 to 8.5. He was on his psych medications and did not have any drug use. So part of this presentation is how do we get to that point where you can treat a patient here or on the streets here and have that same quality of care. But before going into the quality assurance, it's very important to go over the founding principles of street medicine, because without these, even the best quality assurance program will not work. After all, traditional medicine has very good quality assurance programs, but still there was a need for street medicine. So the first one is just the basic idea that everybody matters, and it is because of this that we leave the comfort of our offices and treat patients on the street, dispense medications on the street, draw labs on the street, everything done outside. The second is the idea of going to the people, which is the tagline of the Street Medicine Institute, and there's no better place that demonstrates this than Boston Healthcare for the Homeless, where on the same street corner, on one side of the street, they have a very new, large, multi-specialty, but traditional-looking health center catered specifically for the homeless. On the other side of the street, there's a 600-bed shelter with a Boston Healthcare for the Homeless clinic co-located in that shelter. And then the river that runs through all of those clinics is their street team, who are delivering care to those unsheltered, rough sleepers sleeping outside. So in one street corner, you have 3 different healthcare delivery systems run by the same organization based on how the patient prefers to get their care at that moment. And the last one, which is perhaps our greatest gift, is our ability to share in our patient's suffering and do so with joy, not with grumbling. So only when we're able to do that will they know how much we love them and care for them and be willing to follow any other plan. But this is not a warm, fuzzy type of love. This is like a love with grit. This is a love that bails water out from their tent after it's flooded, or sits with them on a bus in solidarity as they are getting abused or harassed by other people riding the bus. But there you sit as friends. So again, without these basic principles, the best quality assurance programs will not work. So on to the basic concepts of quality assurance. These are from the World Health Organization, and we'll be going through each one separately. So for now, the delivery has to be effective, it has to be efficient, it has to be accessible, acceptable, meaning patient-centered, safe, and the last one, which I think is the most important, is it has to be equitable. So what will really determine most of how your quality assurance program is designed is on your role the role of the street medicine program and the scope of practice. Because the services you provide must match the outcomes that are desired. So you can't expect huge increases in results with minimum coverage. If you're going to be tracking blood pressure control, but you're only going out on the street once a month and you're not dispensing blood pressure medications, it's unlikely that you're going to see a big drop in blood pressure. Or if you're planning on only doing a hospital-based consult service without a robust street program, you're probably not going to see a big decrease in ED visits or hospital readmissions. And a lot of that, frankly, comes down to your organizational capacity. So is your staff full-time? Is it volunteer? Obviously, a full-time staff will be able to see a lot more patients and do a lot more things with them than a volunteer staff. But one thing that's important to keep in mind from a risk management standpoint and from a quality standpoint is that just like any traditional practice, you are responsible for whatever you order, whether it's a medication or a lab. You're responsible for those results. So you still need to be available for phone calls. You still have to be available for the laboratory follow-ups and then reporting those results to the patients. So being a volunteer organization or only doing street rounds twice a month does not absolve you from those responsibilities. The other thing that will determine your role and scope of practice is your community partners, and your good collaboration with community partners is absolutely essential for any street medicine program. One, you have to let the streets teach you how to build your program, and the community partners that are already out there doing work similar to street medicine are part of the streets and part of the culture. So learn what they're doing and how you can best fit into the good work that's already being done. They will also enhance your scope of practice. So for example, when I first started, it was just me as a practitioner going out on the streets, but I was able to find a nurse who was actually part of a different hospital who was at one location all the time. So I knew that I could order labs or dispense meds from that location, and we would be able to team up, and she could follow up on some of those things. The outreach worker that we ended up eventually hiring worked for a veterans organization, and he became our street guide. So, so teaming up with other members of the community will greatly enhance what you're able to do. We will later go into more about knowledge of compliance and risk management, and also the importance of a policy and procedure manual. Medical malpractice is something that we get asked about a lot, and there's 3 things to remember about medical malpractice because unfortunately we need this in order to be able to practice. So 1, if your program belongs to an institution, the institution should cover the malpractice. When we started at Lehigh Valley and here at USC, both programs were made official practices of that institution, and along with that came malpractice. If you're not part of an institution, you can look into registering yourself as a HRSA free and charitable clinic, and there is the link to the website. The DeSales-free clinic at the Allentown Rescue Mission, which was actually the first clinic that we started, is registered as a free and charitable clinic. And HRSA provides free malpractice insurance for all of the providers and nurses that are volunteering. It's pretty easy to do. Lastly, I wanted to put in a word of caution for those practicing with the Good Samaritan law. There is, in the resource page to the bottom of your screen, a street medicine handout on professional liability, and in that it talks about the Good Samaritan law, which is a state law, so it will vary by state, so please check with your own state law. But what it comes down to is that even as a Good Samaritan, you are held to the same level as your training. So if I, as a physician assistant, come across a car accident, what is expected of me is more than what is expected of a layperson coming across a car accident. So that again does not absolve you of the need to provide quality of care. And finally, always consult with your own risk management and compliance department for institutional direction. Some things might be legal for you to do, but your institution is not interested in doing that or taking on the risk, because there is a risk. You just have to be able to weigh that, and if it's something they're willing to accept. So the first QA concept is that the care has to be effective, and there is a value-based versus patient value-based care, which is very important to understand. So value-based care is as the healthcare system is switching from fee-for-service to value, CMS came up with all these qualifications on what they consider good care. And, you know, are you on a statin if your cholesterol is high? Do you, or a ACE inhibitor? And that is in contrast to patient value-based care. So for a lot of our patients sleeping on the street, being on a statin is not their first priority. Their first priority is their basic physiologic needs of housing and food and safety. So when we're coming up with our QA program, we have to make sure that what the patient values is counted just as highly as what the system values. It's not one or the other, but it has to be both. So these are some quality metrics that we track within our own practice from traditional quality metrics, and these are some non-traditional quality metrics. And these are some of the results. So in terms of street medicine, being able to provide equitable care to a traditional practice, in FY17 at LVHN, street medicine did outperform even the traditional primary care practice. We also were able to show improved healthcare utilization. So the patients that we met on the streets were able to decrease ED visits by 73%, total admissions and readmissions by 64%. In the hospital-based consult service, ED visits were decreased by 80%, and the admissions and readmissions by 81% and 68%. The next concept is efficiency. So again, and this is going to be a recurrent theme, is that the goals of care have to be based on the patient's quality metrics. So in street medicine, the most important member of the healthcare team is the patient. And the second most important member of the healthcare team is the patient that identifies with, that is the team member that the patient identifies with the most. And this means that we all have to work transdisciplinary. I intentionally did not put multidisciplinary, but transdisciplinary. All of our resources are scarce on the street, and if a patient really needs a social worker, but they have established a very good relationship with me, just because I'm a PA doesn't mean that I can't do the social work component. So I have to learn as much of that as I possibly can. Obviously, there are restrictions based on what we're licensed to do, but we have to learn each other's jobs, and that creates a flat hierarchical structure. So how this works in practice is whenever we meet a new patient, first we have to establish the goals for the patient, and the patient has more input than anybody on that. So they will give us usually 3 to 5 goals, and we will pick one that we feel that we can meet very quickly. And this helps establish a rapport and trust with them, and then after that, they're more likely to follow up on the other things that we recommend and have to say. The other part of efficiency is being able to work lean. So one of the beauties of street medicine is that you really only need 2 people to run a team. You need a street guide and you need someone to deliver the medical care because it is street medicine. So the street guide's role, and this can either be a consumer, community health worker, or another outreach worker, but their role is to know the streets, know where to go, who needs to be seen, what places you might need to avoid. And then when you're actually in the field, their role is situational awareness. So when I'm doing a patient interview, my attention can be 100% fixed on the patient while they're scanning the environment and making sure that everything is safe around us. And of course, there are many, many other people that have a very large role in a street medicine program. One of the other resources is on volunteer laws, which would be very important to reference as well. So when we talk about efficiency, this was the core staff for Lehigh Valley Health Network Street Medicine. Obviously, I am no longer part of that core staff. But with that staff, we were able to run 3 clinic sites, including a youth and sex trafficking specialty care site. We covered 3 hospital locations and saw over 1,300 unique patients a year. We also were able to do almost 300 consults in the hospital. We had a 4-bed respite. We did telemedicine. We connected patients to medical legal partnership and took an active role in transitioning patients into traditional practices, which is a very important process, but a later presentation. Here at USC, it's going to be very different. At Lehigh Valley, there was no other healthcare being delivered to the homeless. At USC in Los Angeles, there's many, many other people working on behalf of the homeless. So we just started. It hasn't even been a month since I've been here, and we are going through the same quality assurance process that you listening in on this call might be going through too. So from an efficiency standpoint, it is not as efficient for us to start going into the shelters or some of the other traditional practices because they have great HCH grantees out here that are doing excellent work. A lot of the shelters have shelter-based clinics. So our role is really to focus on the medically complex rough sleeping population. And we have to do this in close collaboration with our clinic providers and link them to traditional primary care when we can. And we're currently working through the same process. And now I will turn the presentation over to Laura.
So as Brett had stated, the primary goal is to go to the people. So wherever they are, that's where we're going to be at to deliver health care. So soup kitchens during mealtime, shelters where they're sleeping, or, daytime programs in the shelter locations, or whether it's going, into the woods or under the bridges. A huge part of what we do really requires us to be consistent. We need to have frequent visits so they know where we're at, where we're going to be with our predictable schedules. We have a rotating clinic schedule that is the same every single month. Our continuity of care piece is huge. So if we get an inpatient consult, we see that patient, and then we try to have them follow us up outpatient. If it's an outpatient individual and they get admitted inpatient, we'll then follow them inpatient, let them know that we're there, and then follow up with them again outpatient. That continuity piece is huge with our trust building, and it allows us to refer those people over to traditional practices when we're able to. In our clinic locations and wherever we're delivering care, we make sure that we have the necessary items with us so that we don't have to send the patient elsewhere to receive that care. So as Brett said, we deliver medications on site. We do lab testing on site. We'll draw blood wherever we're at. And we have point-of-care testing. So we have a hemoglobin A1C. We have a glucometer. We have a point-of-care EKG machine that reads directly to my work cell phone. And we're going to take a poll really quick about medication dispensing. So do you dispense medications on the street, if you guys don't mind answering? All right, so it looks like the majority of you are not dispensing. Okay. So prescribing versus dispensing. So prescribing is the ordering of the use of medication, as where dispensing is the preparation, packaging, and labeling and record keeping and handing the medication to the patient. So prescribing is just giving them the prescription versus dispensing where you're actually giving them the actual drug. This is versus administering. So that's transferring the medication for immediate use. So prescribers are the only ones that can dispense. Administering can be done by somebody that is licensed, such as a nurse. Again, so providers and pharmacists can dispense what they're licensed to prescribe, and any medications that are handed out to the patient, if it is not a one-time use, which is administering, has to be done by a prescriber. This is over-the-counter medications such as Tylenol, Zyrtec, Allegra versus a prescribed medication that requires a prescription such as lisinopril. So for our street medicine policy for prescribing, we do not do any narcotics, benzodiazepines, or other controlled substances. This also helps to deter any drug-seeking behaviors. Our street medicine employed providers may prescribe psychotropics. However, we do not have our volunteer prescribers prescribe psychotropics. And the reason for that is whenever you have a volunteer provider, say an ED provider that's at your clinic on a Tuesday night, they may not be rescheduled to volunteer at that clinic for another quarter. So there's no follow-up to see if that psychotropic medication is working for that individual or not. Medications that are not prescribed that are not available on site, we can actually send over a prescription to one of our contracted pharmacies through our electronic medical record, or we'll hand them a paper script. So we have our health spectrum pharmacies that are contracted with our program. They're located within all of our hospital settings within LVHN. Our Family Prescription Center is a mom and pop pharmacy, and they have graciously contracted with us. So anybody who sees street medicine and gets a prescription by us, whether they have insurance or not, the fees and copays are then covered by street medicine when necessary. If we have somebody who, can afford their copays, or they say, I don't have a problem, handling a dollar fee, then we'll let them take care of that. But we do help whenever it's necessary. Whenever we hand out medications or dispense them in our clinic sites, You can see the medication label, which is up top there. That has to be filled out and placed onto the patient's bottle, or we are currently using the blister pack medication. So there's the RX number, the date and the date of birth, patient names, the instructions, and expiration dates. All of those medications that are dispensed are also then logged onto our patient practice stock log. So that way if there's any medications that are being recalled, we can pull these up and take a look at it. We are currently in the midst of working with Epic, which is our electronic medical record here at Lehigh Valley Health Network, to track this electronically, so it's no longer going to be done on paper. That is not in place yet. Medication storage. So any medication that you have with you for dispensing requires a double lock system. So our network has decided that it needs to be in a fireproof cabinet, and that is your first locked item, and then behind the locked door for the clinic, and that's at any of our clinic locations. For our book bags, for our providers that carry medications with them, their book bags need to have a little lock on it, and then that's your first lock system. And then if you keep it in your car or in the office, that's your second lock system. When keeping it in your vehicle, you need to be careful. All medications need to be kept at room temperature, which is 68 to 77 degrees Fahrenheit, unless it's needs to be refrigerated. The backpack versus the truck scenario, our backpacks go into a regulated environment, like I said, into the office or into our vehicle. The biggest concern with our medication truck that we used to have when we would do street rounds is the fact that it was not, the environment was not regulated. So there were times where we did get above and below our room temperatures, which then we would have to contact the pharmaceutical companies. Our vaccines, our biggest problem is our influenza vaccines. They need to be maintained in a refrigerator temperature of 35 to 46 degrees Fahrenheit, which is per our LVHN policy. Whenever we would do vaccines, we would have to pick them up from a refrigerator that was being monitored on a daily basis to make sure it was within the right temperature range, and then transport it to our clinic sites that did not have refrigerators. These vaccines you're not supposed to have out for more than 30 minutes outside of that temperature range. So you have to sit down and take a look at, are we going to have a cooler? Are there going to be ice packs in it? Or do we have a thermometer to keep inside of it? And then to take them out on street rounds really is not viable unless you have something that you can carry them in that's going to keep it at the right temperature while you're out there, especially in the summertime. Our laboratory testing. So our street medicine program complies with our Lehigh Valley Health Network laboratory standards. We do have a lab license that is in place, and the lab license does include our point of care testing, our clinical chemistry, so our hemoglobin, our whole blood whenever we're drawing phlebotomy on site. All of our items are CLIA waived. Our influenza A and B swabs, those are CLIA waived. And then we have a lab director that actually oversees all of our lab documentation. And we report everything as a regular traditional practice would. We do patient safety reports if something's not done right. We have a checklist for corrective actions for specimen mishandling or mislabeling use. And we do have a lab contract where we can drop off our specimens and or have them come and pick them up at our designated locations. And each place has, a special client ID number with a protocol on who to contact if we have labs that are of critical value. And then we have quality controls that are required for all of our point of care testing that we do, and we keep track of those on logs. So our laboratory specimens, the items that are collected at the site of care gets a customized laboratory requisition slip. This is a carbon copy item. This is completed in entirety, and the reason why we utilize this is there is a little checkbox that you can't see, but it says to bill the practice. For our individuals that do not have insurance, this item is critical to ensure that we get the fee and they do not, and street medicine covers those fees for them. The lab requisition slip has on there the lab orders. This is as good as a prescription. We also do put it in the EMR just for good measure, but this gets put into the biohazard bags and the specimen bags, and we take them over to the clinic. Bootsy asked if there's lab testing and if I can explain what a CLIA waiver is. So the lab testing. The CLIA waiver is our, Brett, what do you think is the best way to explain the CLIA waiver is? It's a certificate stating that their results, let me put on here.
So CLIA is a certificate that labs have to be CLIA certified. And for the point of care testing, they can get a CLIA waiver for that. But it's, I'm sure I'm definitely not an expert in CLIA. I'm sure there are other things, but mostly I've seen it in point of care testing or any sort of mobile device that you're bringing with you. Okay. CLIA requires a device to be fixed and then the controls to be done on that fixed device, or else it has to be recalibrated.
Okay, thanks, Brett. So then we have all of our, like I had said, that all of our lab work is ordered online in the EMR, which is our electronic medical record. We use Epic here for clinics that do have access to the EMR. We do have one clinic site that is strictly done on paper. So paper prescription or the customized laboratory requisition will be utilized there. Our laboratory testing point of care, like I said, all of our point of care tests have a patient record. So this is where we take the quality control. We quality control each one of our devices, such as our glucometer, before we use it on the patient. If anything is out of range, then we follow appropriate protocol as per our LVPG lab and follow the manual instructions if your quality control is not in line or within range. Each one of our point-of-care tests is checked at the time of purchase and annually to ensure that it's working properly by our biomed group here at Lehigh Valley Health Network. Each one of the devices is tagged with an ambulatory ID number to make sure that the appropriate device is going and being checked on a regular basis. We have our quality control, quality control and patient record, and we do hang on to that to make sure that we didn't run any checks that were expired. The machine itself, it was calibrated right, and that all goes to your lab director for signature. So we allow our street medicine program to be built by the people. So like I said, we go to the people. We deliver health care on the streets, in the soup kitchens, and the shelters. We deliver wherever people feel most comfortable. And the way that we learned how to adjust our program is by actually listening to the needs of the people. So by hearing somebody say that they are more concerned about whether they're going to get their next meal first versus an elevated blood pressure, we then do a root cause analysis as to why are we not getting food. And if we find out they do not have food stamps, we sit down with them and we complete in Pennsylvania what is a PA Compass application where we can apply for food stamps and Medicaid all at the same time. You know, they are complaining of their feet being sore from walking the 5 or 6 blocks. Our program now has initiated a donation closet here within our network where we accept donations of shoes and clothing, and we deliver those items to our patients. So if somebody has a bum pair of shoes that they're blowing out from all the walking that they're doing, we can hopefully provide them with the right size and keep those feet clean and healthy. We've placed all of our clinics in convenient locations of care. So we go right where they are. We're going to have our soup kitchen during lunch hours. We're going to have, we're going to have our clinic during the soup kitchen lunch hours, or we're going to put our clinic right outside of that warming station where people are waiting in line at 5 p.m. And we're going to run clinic out of an RV there at 5 p.m. every night. We assist them with things such as insurance, transportation. How am I going to get to that specialty appointment? How am I going to get over there to pick up my medications? So we've worked into our program bus passes, and we give bus passes out to patients that we've made appointments for, prescribed medications for. We have the point of care testing in our clinic sites so they do not need to go to the lab. We can do those right there. Housing, we do a lot of transitional housing referrals and HUD housing applications with our patients because that is something that is most important to them. and other items such as identification. You can't get into housing or a birth certificate without ID. We work on all of those items because that's what our patients are asking for. Those are their goals. So we meet them there, and hopefully we can bring in their health care at the same time, and it normally works pretty swimmingly. Cultural cues and code of conduct. So whenever we go out, particularly on street rounds, we always announce ourselves. Our outreach worker, you can hear him in all of our videos that we have online. Street medicine, this is Bob, does anybody need anything? He always loudly announces. We never just walk into somebody's location without letting them know who we are and what we're there to do. We're always considerate. We don't, you look at the ground, make sure you're not stepping on their belongings. This is their home. Even if it's under a bridge, it's their home. We're very respectful. If they want to focus on getting into housing versus seeking drug treatment, we focus on their goal of housing first, and then we help guide them along the way to getting the treatment that they need from there. Ask what they need. What are their goals? Where do you want to be tomorrow? What is it that we can help you with today? Mind your manners. You need to be considerate. You don't bring dogs out with you to their campsite without asking them in advance. And never commit to anything unless you're certain that you can deliver. We never tell somebody, yes, we will do that for you, unless we know for a fact that that is something that we can follow through with.
All right. Thank you, Laura. Before going into our last QA concept, I just wanted to point out that in addition to the professional liability handout in the resource section is also the complete LVHN Street Medicine Policy and Procedure Manual, all 82 pages. So if there's anything that we went over in this presentation that you want more detail or want to know how exactly it was worded in the Policy and Procedure Manual, it is attached under the resource section, and it's very well indexed, so you don't have to read all 82 pages. So the final concept is that the care has to be equitable, and this is really the take-home slide to show that what the overall aims are. So the goal is to deliver the same high-quality care on the street as you would expect in a clinic. We are held to the same standard under the law, but also they deserve the same standard. The patient defines the goals. And then lastly, we have to reimagine how we define success. So the traditional definition of success, that their blood pressure is controlled, that they're wearing their bike helmet, that they got their mammogram or colonoscopy, which can you imagine prepping for a colonoscopy living on the street, just don't apply to our patients. So we have to reimagine how we define that. One example is this patient who basically made a home on this bench. By all traditional measures, he was a failure. We never got his COPD controlled, we never got him to stop drinking alcohol, and we never got him into housing. But when he was admitted to the ICU with terminal illness, we were able to come in, make sure that he was reunited with his family after many years, helped him with his goals of care, and were there with him when he finally passed away. And afterwards, his body was delivered back to his family for a family burial rather than a mass grave with the county. But perhaps the most glaring image of success is Pappy. And Pappy believes that we are just as much part of the street culture as he is. And being accepted into that culture, it is the most important definition of success. And Pappy is here panhandling in his street medicine t-shirt, and there's nothing more beautiful than Pappy. There's our contact information. Feel free to email at any time.
Thank you, Brett. This was an incredibly helpful presentation by my estimation. I know that we've got some questions coming in already, but I just want to make sure that everybody knows is alert to the Q&A box below the presentation slides so that we can address them one by one. And again, just to reiterate, our presenters have been extremely generous in letting you see the whole 82-page manual that they created at Lehigh Valley. So if you are unable, I know a couple of you have said you are unable to download it, it will also be with the archive of the presentation on our website. So we will follow up with that. So let me get to a couple of questions you've already addressed. Clea. So Andrew says, to maintain support from the administrative team, we need to meet productivity goals. What is a reasonable goal for patients seen in an 8-hour day practicing street medicine? Brett or Laura?
Yeah, I'll take that one. So if you're, first, it depends on what stage of development your program is in. So if you are a brand new program, a lot of your time is going to be spent establishing relationships with the patients and with community partners, and you're not necessarily going to be cranking out patients. And also just finding where they are. If you are an established program, you know the community partners, the community knows you, and it's a full day on the street, you can easily see 10 patients a day. There are patients there were times at Lehigh Valley when we would see 20 plus, but I don't think that that's typical. I would say 8 to 10 would be safe.
Okay, thank you. Let me turn to the next one. Have you had a client who was getting care from you for a few months and then stopped care? What do you do in that kind of situation?
I think that depends mostly on why they stopped getting care. So if they stopped because they were mad at us for some reason, then obviously we would try to address that. And but if they're just lost to follow-up, which I think might be what this question is asking, just like in a traditional practice where you document, if somebody's a no-show, you document your phone calls, then you send a letter, and every practice has their own protocol that they follow. And we don't do the exact same thing. Obviously, we don't call twice and then send a certified letter. But we do document in the EMR every time we go out looking for the patient or every time we make an attempt to reach out to them, just like a traditional practice would.
Great, thank you. Let's see. How do you register patients in EPIC or the EHR when they're not willing to give their real name or date of birth or other information like that?
You want me to take that, Brett?
Yep, go for it.
Okay. So we do have individuals who have aliases and prefer not to give us any of their real information. So we create it based off of whatever it is that they happen to tell us. If they are a John Doe and it is they give us a random date of birth. We have had individuals that, told us they were born in 1986 and they definitely look like they're, mid-60s, early 70s. We have to go off of whatever it is that they're willing to give us. We do update the information in EPIC as the relationships are built and they gain trust in us. We have people who have had warrants out for their arrest, and they were afraid that we were going to turn them in, gave us false names. But through working on building that trust, then we can update their information in our electronic medical record, and then we just include all those other aliases and names in that location. Obviously, when you do things like change a date of birth or change a sex, there is a requirement for you to put in a note and notify your medical record team that this is what we did and why we did it. But we go by whatever it is that they're telling us at that point in time to get them into the system. If we find out that John Doe is really Robert Smith, then we merge those charts if we find out they're already there in existence.
Thank you, Laura. There was somebody who's asking if there is a resource list of clinics currently active in each state or in major cities. I will ask Brett from the Street Medicine Institute perspective to address that, but the National Healthcare for the Homeless Council certainly has a list of healthcare for the homeless programs, and we can, I don't know if we have a list specific to or whether they provide street medicine services, but if you follow up with the council, we can certainly direct you to any kind of specific region you're looking for. Brett, I'll ask you, does the Street Medicine Institute have like a list of programs, a directory?
The Street Medicine Institute does have a list, and we just revamped our website. It's www.streetmedicine.org, and there will be a list available to members. But if there's a specific city that you're looking for, feel free to email me and I can try and connect you.
Great. The next question has to do with patient surveys. They say they're hoping to design a simple patient survey to help track outcomes and success, but they're concerned that this is an imposition and not in real time addressing a patient's goals or needs. Do you have thoughts on that?
Sure. So I think the best way to survey this population is just to work the questions into conversation, and of course ask them if they're willing to participate in the survey, if it's going to be an official survey. And of course, you might need approval to do that. And in my experience, it hasn't been an imposition for them. But then to address the second part of the question about not in real time addressing the needs or goals, it depends on what you do with the survey. So if you're simply just administering a survey in order to get some research information or even help develop your program, then that might be a little bit of an imposition, but I would do your best to address whatever goals or needs you can as a result of that survey in real time, even if it's something simple.
Yeah. Thank you. I guess this one could be for Laura. Do you have MOUs with the clinics and shelters that you partner with?
Every location that we deliver patient care, if it's in a shelter or in a soup kitchen, we do have a memorandum of understanding with each one of those locations. And our Valley Youth House, which is our youth clinic up here, they do have an RV that we utilize that space also for our winter shelter clinics, and we have that worked into our Valley Youth House MOU also. And
Great.
That's all been addressed by our lawyers within the network.
So the next question is, how do you define ED diversion for reporting purposes?
Actually, we've never defined ED diversion, and it's not part of something that we report on. Part of the reason for that is because it is so difficult to define. So if we were to pull out 100 patient visits and say which of these visits would have resulted in a ED visit if we weren't there, would just be speculation. So instead of tracking ED diversion, we just track ED visits, the actual decrease in ED visits, which has been enough. If you refer to some of the data, the visits have decreased by over 70%. Of course, there were many ED visits that were diverted, but we don't have any hard evidence to show that.
Okay, great. The next question is, what do you do if a patient has relocated or you're unable to find them where they usually are over a period of time? How do you try to find them, if at all?
Do you want me to take that?
Sure.
So we do everything under the sun to try to find our patients that we haven't been able to locate. Everything from, getting into our electronic medical record to see if they've been recently admitted to the hospital, they had an ED visit, if they have a primary care provider that they were seeing, see if they've been in there. We touch base embedded in our practices within the network. We have community care teams that are made up of behavioral health therapists and social workers, so we ask them if they've seen or heard from them. We work very closely with our external agencies for our homeless populations, so we'll reach out to our friends there. We have called the prisons. We've called neighboring shelters in other counties. It is detective work just to make sure people are safe. We'll call the coroner's office to find out if John Doe has shown up there.
And if a person has truly relocated and we know that they relocated, then we will contact, if there's a street medicine team wherever they went to or a hospital system near them, but we will attempt to transition care to wherever they are.
Great, thank you. This is an important question. How do you handle an individual who is here on an expired visa, has no health care insurance, I assume, and has serious medical issues?
I'll take that. So that's actually been a very important issue here in LA. When I talk to a lot of the folks outside, they're very concerned about ICE coming to get them. But to be honest, we don't see that as something as our role, so it doesn't matter to us if they have a visa, don't have a visa. Our job is to just take the best care of them that we possibly can. If they need health care and don't have a visa, we can still get all their medications for free and all their labs for free. If they have a very serious medical issue that requires something more than what we can deliver on the street, then we have to work through the appropriate channels to get them what they need, of course, with their approval.
With Lehigh Valley Health Network, there's a financial assistance program, so we have our individuals who are uninsured or underinsured complete it. And for the standard population, they get about 75% of their medical bills waived. Our network has granted our street medicine patients 100%. So our individuals who don't have any insurance, whether or not it's an expired visa, they can get into one of our outpatient practices within the network and have their fees 100% waived.
They don't check any visas or anything?
No.
Sort of a follow-up question. How do you address literacy issues or if a person is in need of a translator, English is not their first language? For example, Spanish speaking or sub-Saharan or something like that.
Yeah, that's a great question. So two things we can do. One, we have remote access to the hospital language line that the hospital subscribes to and they pay a fee for, so we can remote access into that. And at Lehigh Valley, you could actually do teleconferencing with a live translator, which had its positives and negatives, but overall was positive.
Right, and I think most health centers are required to have those kinds of services too, not just hospitals.
Yeah.
Trying to get to a few more of these. What quality measures, how are they addressed or managed? How are measures impacted by patients who may not be traditionally successful, kind of following up on your earlier point, Brett?
So the more traditional quality measures are usually just built into the EMR. And actually, Laura, you have a very methodical way of following up on those if you want to talk about that.
Really, Epic just has a report system that every outpatient practice gets pulled on a monthly basis. So it's just a report that's already created within the system. I pull it up every week, and we make sure that our program is falling in line. There's a comparative between our program versus every other traditional practice in our network. And, our network chooses its own goals, and we just see if we're in line with them. And then we focus on how do we make that better.
Yeah, and then the second part, how are measures impacted by patients who are not traditionally successful? Yeah, that's part of it, is that they are usually negatively impacted by patients that are not traditionally successful, and that's just part of street medicine. And that's okay because we don't do this for the metrics. The fact that the metrics are even comparable, I think, is an accomplishment.
Yeah, I was going to say, overall, our people are not typically successful, but our measurements are almost spot on with our network's goals, the entire network's goals.
So I'm going to address Bootsy's other question. Early in relationship building, someone isn't yet officially a patient, but we're getting to know them. Would you make a provisional note in the EMR or EHR to document contact, even if it's just an introductory conversation with someone you just introduced yourself to?
So I have our team and our outreach worker document those encounters because it is important to establish that you have reached out to them before, put a little bit of their story or information. We do this particularly with our Truth Home patients. We put a little bit of background to help others understand where they're coming from and why potentially their healthcare or mental health looks the way that it does. That way you have some sort of a foundation for whenever you do start delivering healthcare.
Great. So the last question that has come in, if you have any questions you haven't typed in, please do so now. Matt asks the perennial question in this work is how are the majority of street medicine programs funded? I could respond, Brett, I guess I'll let you take that.
No, go ahead. Go ahead.
Well, I only know that the healthcare for the homeless health centers and other health centers largely just expense that to their health center grant. The health centers have a myriad funding streams, just like any nonprofit. Some range from 95% of their budget being from the health center to 2%. But that's sort of the health center perspective. But other kinds of programs, I'm sure Brett can kind of speak to.
Yeah, we actually did kind of a unofficial poll at the Street Medicine Symposium about this, and there was definitely not a majority of anything. It was pretty much everything you could imagine, from being institutionally funded to not funded at all, to having a patchwork of grants. It really is just like you let the streets build your program, and that's going to be different in every city, so is the funding different in every city. But Matt, if you have a specific question about your program, I'd be happy to answer it if you want to email me.
Just one or two more before we conclude. Can either of you speak to the role of community health workers besides what you've already defined on the street?
Go ahead, Brett.
You can do that, Laura.
Okay. So our community health worker, his goal is to go out to the campsites, figure out which ones are active, which ones are not active within our program. He is the one who decides what our street rounds are going to look like. He lets us know who is ill, who has been missing in action for a while. He goes out. He's the first contact. He's the individual that introduces himself as an outreach worker for street medicine, lets them know what we're doing. He's their first trust point. And then he brings us out to follow up with those individuals and meet them and build our trust groundwork with them. Our outreach worker also, our community health worker also does outreach, patients that have been in the ED that we weren't able to get for a consult. He'll reach out to them, try to figure out where they're located at, how can we get health care to them, can they come to our clinic for us. He also decides what kind of donations and supplies that we need to ask for from our network whenever they do donation drives, or what needs to be taken out to campsites. But he's kind of like our safety guru, and he's our first foundation for setting up those relationships with our homeless populations, amongst the other things that Brett had said.
Great. Well, Brett and Laura, we need to wrap up. I want to thank everyone for joining us today. This webinar will be archived on our website, nhchc.org, within 3 business days, and a link of the archived webinar will be emailed to registrants once it is posted to our website. If we were unable to get to your question today, and I see Anne, I will follow up with you later, please contact the council through our website and we'll get in touch. Once we adjourn in just a moment, an online survey will automatically appear in your web browser. Please complete that survey so that we can use the data to improve our work. Thank you again, everyone. This meeting is now closed.